Dave Hashey. I'm a pharmacist and a professor at the Department of Family Medicine. And in this unit, we're going to be talking about hepatitis, specifically hepatitis A, B, and C. The main objectives that we're going to cover are fairly broad. First is we're going to be talking about some of the regional and national epidemiologies of hepatitis A, B, and C. We'll talk about the different screening and confirmatory testing between the three different types of hepatitis. And then we're going to talk specifically about hepatitis C and the hepatitis C care cascade and its impact on public health. We'll also talk about different resources to link patients to care, discuss common medications for hepatitis C, and look at harm reduction resources for persons at risk for contracting hepatitis B and C. Before we dive in talking about the specific types of hepatitis, if we just step back and have a historical perspective, it's important to understand that hepatitis has evolved over the course of time as science has improved and we have a better understanding. Hepatitis A used to be referred to as infectious hepatitis, partly on how it's transmitted, but that is a term you may see in some of the previous literature. But infectious hepatitis went on to be categorized as hepatitis A. Then there was serum hepatitis, which here in the U.S. is primarily hepatitis B, but you'll also see some hepatitis D or delta referred to in the literature. And then for a long time through the 70s and 80s, there was what was referred to as non-A, non-B hepatitis. We knew it wasn't hepatitis A, we knew it wasn't hepatitis B, but we didn't know what it was. It was eventually identified primarily in the U.S. as hepatitis C, and it was identified as being transmitted primarily parentally, also through blood transfusions several decades ago, and because of that, that was a major mode of transmission before blood supply was being screened. Outside of hepatitis A, B, and C, you may see in some of the literature hepatitis E. It's not very prevalent here in the U.S. You may see it in other parts of the world. Same thing with hepatitis F and G, very uncommon. But talking about hepatitis A is a significant form of hepatitis that is found across the globe and has varying prevalence. However, one common thread is it is usually found in areas of low socioeconomic status, whether areas of poverty, areas in which there is poor sanitation, access to good plumbing, toilets, and so forth. And part of that is because the transmission of hepatitis A is fecal-oral. So usually the virus will shed in the GI tract and active virus will be eliminated in the feces in individuals who do not wash hands, or just because of the high burden of virus, it may be easy to transmit for individuals who do not wash their hands, handle food, or other things in which the virus is then transmitted to the next person. In the U.S., outside of a few isolated outbreaks annually, whether food, in the homeless, or in daycares, a lot of the hepatitis A that is seen is in those individuals who travel. And a lot of times it's travel to either Mexico or South America, where patients may be infected on vacation and return to the U.S. and then bring the case with them. But as I mentioned, there have been outbreaks associated with food handling. The incidence of hepatitis A over the last several decades, as you can see, has ebbed and flowed. And we started seeing a massive decline in hepatitis A with the introduction of more global and universal vaccines, especially in children, but also in those adults who have major risk factors. However, when we look at more recent trends in transmission data, we see that we've had a significant rise over the last several years. This has been seen primarily in patients suffering from homelessness here in the U.S. And as part of that, we've expanded recommendations for hepatitis A vaccine with, again, broader use of the vaccine. I've already alluded that hepatitis A transmission is primarily fecal to oral, but just to dive a little bit deeper, again, it is from person-to-person contact. Usually can be seen with transmissions in households, especially in children who are infected or infants infected with hepatitis A, who may not show a lot of signs, but may be transmitting, shedding the virus. And for those who have not received the vaccine, individuals may contract it fairly easily. There's also sexual transmission or transmission in residential institutions, daycares. It's been seen in military personnel. And the one I've highlighted here is those individuals experiencing homelessness. And that has been one of the major subpopulations that have experienced hepatitis A. Also, in contact with contaminated food or water, a lot of times with food that may be brought into the U.S. That may be contaminated or handled by individuals who are infected. And rarely through blood transfusions and sometimes people who inject drugs. In the interest of time and for you as a learner to look for other resources, there is a link out to different videos that will help emphasize the disease course. But essentially, individuals who are exposed to the virus will have a sharp rise in virus replication within their body, followed by symptoms such as jaundice, fatigue, general flu-like symptoms. And because of that, it may be patients may not always seek medical care. And hepatitis A is diagnosed by laboratory studies, by somebody having antibodies to the virus. There are two different types of antibodies. The first one is referred to as IgM, which is an acute response to exposure to the virus, and then IgE, which persists for decades, develops several months after the exposure, and is protective. The IgG antibodies is also what is developed after the vaccine. Chronic hepatitis A does not exist in the concept that we understand chronic disease, but there are instances in which some patients may have relapsing remitting hepatitis A, but again, very uncommon. There are no specific antiviral medications or treatment for hepatitis A, primarily supportive treatment. 85% of infected patients have a full recovery within 3 months, and fatalities are extremely rare with hepatitis A and may occur in individuals who have pre-existing liver disease, cirrhosis, or other forms of hepatitis on top of that. And I described briefly relapsing hepatitis A, very uncommon, but some patients may experience a relapse during 6 months after an acute illness. The Advisory Committee on Immunization Practices, or ACIP, has very strong and clear and well-supported recommendations for hepatitis A vaccine. And outside of general recommendations for children and adults, we have what's referred to as pre-exposure use as well as post-exposure. Pre-exposure is used in individuals who are traveling internationally to areas of high rates of hepatitis A who have not been vaccinated. The vaccines were approved back in the 90s, and the patient should be vaccinated as soon as they know they are going to be traveling, preferably 6 months so they can get both doses of their vaccine, but at least a couple weeks before travel. There's also an option of a drug called immune globulin, and this is passive immunity in which the individual, along with the vaccine, can get an injection of this immune globulin, which provides passive immunity for about up to 6 months. Then there's post-exposure. Let's use an example of an outbreak that may happen at a food service location. Patients identified as having hepatitis A, notification goes out to the community. If you have eaten at this location in the past 2 weeks, you may be a candidate for a vaccine if you have not been vaccinated. So within 2 weeks of an exposure, individuals can receive the vaccine, which is extremely effective at reducing transmission if given within that 2-week window. Individuals who may have a contraindication to the vaccine may use immune globulin, but again, the vaccine is preferred. Here's another table representing the different approaches to both vaccine as well as the dose of the immune globulin for both pre-exposure and post-exposure prophylaxis are options. The dosing of the vaccine, hepatitis A, there are 2 commercially available formulations available. Both of those are 2 doses. The volume may depend on the age, but still dosing at time 0 and then between 6 and 12 months. Now, hepatitis B. Hepatitis B is a very complex disease state. And with that, there are very complex mechanisms of disease pathology, transmission, and treatment. We're not going to dive into a lot of the complexities, but I do encourage you to go to the University of Washington's Hepatitis B Online course, as identified in Unit 1, to supplement some of the education. Looking at the geographic distribution of hepatitis B, it is very prevalent worldwide. However, in the U.S., it has a very low prevalence. But in India and parts of sub-Saharan Africa, you can see much higher rates of hepatitis B, as well as in China and Southeast Asia. And as hepatitis B has been tracked by the CDC for decades, you can see that there was a high point of this disease prior to vaccines being introduced. And once the vaccines had been introduced, we saw a massive reduction over time. And nowadays we have essentially universal hepatitis B vaccine recommendations. So having this broader use of the vaccines has dramatically reduced hepatitis B transmission in the U.S. Most of the hepatitis B that is seen in the U.S. Occurs in foreign-born individuals, primarily in those from Asia. Therefore, if you are working in parts of the U.S. where there are higher pockets of Asian communities, you may see more. However, it is fairly uncommon to see it in U.S.-born individuals. The other thing to note about death from hepatitis B is that hepatitis B and hepatitis C cause chronic changes to the liver. And because of that, there are higher rates of liver disease, liver cancer, and we have seen a massive growth in liver-related deaths over time with the projection that it may increase. Whereas we have seen a reduction in deaths from things like HIV. So from a public health perspective, it's really important that we are able to continue to reduce hepatitis B transmission and effectively treat it. As far as the transmission of hepatitis B, it is considered a sexually transmitted disease, but it is transmitted via other methods, including injection drug use, vertical transmission from mother to child, contact with blood or open sores with an infected person, occupational exposure primarily through needle needle sticks, and then sharing items such as razors, toothbrushes with an infected person. So looking at the risk factors, a lot of those translate, including infants born to infected mothers. Moms should be screened, and infants exposed to mothers who are hepatitis B positive have a very high likelihood of going on to develop chronic hepatitis B. That's why, from a public health perspective, it's very important to screen mothers as well as administer hepatitis B vaccine at birth. Sexual transmission occurs seen in men who have sex with men, those with multiple sex partners, and those whose partners are infected with hepatitis B. Injection drug use, household contacts, and hemodialysis are also listed as risk factors. I also mentioned that hepatitis B is a very complex and dynamic disease process. And just as a brief introduction, you can also view hepatitis B transmission patterns on YouTube, looking at the CDC's website as well. But just as a brief summary, for those individuals who develop chronic hepatitis B, and again, not all hepatitis B goes chronic, some people will clear it, but for those who have chronic hepatitis B, there are different phases that they may go through. They may have high levels of hepatitis B, and with those high levels of hepatitis B, the liver may have a lot of response and damage to that. So there is this immune response and this immune activation. But as the immune system kicks in, we may also see the disease get a little bit controlled. And as that disease controls, the inflammation may settle down, but over time there may be reactivation. And this can cycle and happen really through any dynamic process. And patients with chronic hepatitis B really should be referred to and cared for by a specialist either in infectious disease or in hepatology. In shifting and looking at indications for hepatitis B, really at this point there's universal hepatitis B vaccine recommendations for all infants and all unvaccinated children under 19. And it's sort of getting that way for adults, but really for adults, vaccines should be given for those at risk of acquiring hepatitis B, but also anybody requesting it. If they walk into the health department, into a pharmacy, into a clinic, and say, I want to be vaccinated for hepatitis B, that vaccine should be administered, given they have no contraindications. There are a couple different options for hepatitis B vaccine. There's what is referred to as the standard dose. These were approved in the 90s globally. They are thimerosal-free or preservative-free. It is made up of highly purified hepatitis B surface antigen, which creates an immune response without having any risk of transmission of the virus. And it is usually a standard 3-dose vaccine at 0, 1, and 6 months. In some cases, there may be a need for 4 doses at 0, 1, and 2, and 6 months. And then in 2017, a newer recombinant vaccine, adjuvated vaccine, was approved and made available on the market. And the major difference between this novel dose as compared to the standard dose is that it is only 2 doses times 0 and 1 month. So there may be higher rates of vaccine completion and also seroconversion in certain circumstances. Here is a visual representation of the different vaccine types as well as schedules that is pulled from the Hepatitis B online course. And you can see the different brands of hepatitis B vaccine. Heplisave B, which is the novel, is 2 doses times 0 and 1 month. And then the standard doses for Engerix and Recombavax, and Twinrix has both hepatitis A and B vaccines in it. All of those generally are times 0, 1 month, and 6 months. And this is a bit more of an in-depth table for your reference that summarizes the different types, the different ages. The one thing to note is that Hepatitis A B, the novel, newer one, is not indicated yet in individuals under 18, nor in women who are pregnant. There's also the combination of hepatitis A and B vaccines, such as Twinrix, in which those vaccines, you're usually giving 3 doses of hepatitis B compared to 2 doses of hepatitis A as compared to 3 doses. Lastly, hepatitis C. Hepatitis C is again a different form of hepatitis. This is an RNA virus, has some similarities as well as significant differences. But looking at the epidemiology, going back into the 80s, until this was identified as hepatitis C and not just as non-A, non-B hepatitis, the major routes of transmission were through blood transfusion. And once the blood supply was being screened, we saw a significant drop in transmission of hepatitis C. But as you can see on the tail end of this graph, the slope slowly starts to increase. And that increase has been seen because of the opioid crisis, and we'll look at that here shortly. But prevalence, again, is the amount of persons living with hepatitis C at one time. And what's unique about hepatitis C is that we have new infections, and a small subset of persons with new infections will clear the virus on their own, and they will essentially self-cure. But those who develop chronic hepatitis C is represented in this gray cylinder in the middle. Some will go on to die either from hepatitis C-related causes or other causes. Others will be treated to cure and will come out of this pool. Some of those individuals may be reinfected. Hepatitis C, for those that are cured, may have secondary infections if they have ongoing risk of transmission. And again, the epidemiology, as I mentioned, we've seen an increase in rates. And when we look at the distribution is in those younger individuals and those who are identified as baby boomers born between 1945 and 65. And the reason for this bimodal distribution is the older population, primarily that disease transmission and infection is seen from the blood transfusions, although injection drug use and other reasons can also contribute to that. In the younger population, that is most likely seen from the opioid crisis, injection drug use, and because of that, we've seen this spike in transmission of hepatitis C. So the major risk of transmissions in the U.S. are from injection drug use, but other ones include transfusions prior to 1992, when the blood pool had started to be screened more regularly. Those undergoing solid organ transplant, men who have sex with men. Hepatitis C is generally not considered a sexually transmitted disease, but it has been documented in the men who have sex with men community. Body tattoos, this is generally seen in tattoos that are done in non-sterile environments. And then lastly, because the virus can live outside the body on drug equipment, those who share drug paraphernalia, even with intranasal drug use outside of injection drug use, may also see risk of transmission. After somebody is infected, there is a general natural course for people who go on to develop chronic hepatitis C. But it's a very slow process, and patients may not exhibit any symptoms. So unless we are doing universal screening, which we should be, patients may go on with hepatitis C for years without any symptoms that are recognizable. But sometimes after 10, 15, 20 years, we can see some inflammation of the liver, can see some changes in the contextual appearance of the liver, the cellular structure of the liver, and those individuals may go on to develop end-stage liver disease, cirrhosis, or cancer. And that is represented in kind of both of these pictorials. But for those individuals who may be treated and cured, we can stop some of that progression before it gets to some of those later stages. One of the concepts that was introduced from a public health perspective several years ago was what's called the hepatitis C care continuum. And what is great about this is that through public health surveillance and understanding of treatment, we were able to identify that, and again, this is years ago, that there were about 4 million people living with hepatitis C in the US. Only about half of those were actually aware of their diagnosis. And then you can continue to see the fall off in patients accessing care, patients undergoing treatment, and actual patients being cured. This is older national data, and more recent data suggests that all of these, through public health approaches of screening, better access to care, better medications, have improved all of these outcomes. But taking that first step in diagnosing hepatitis C, there is universal screening that is suggested, and you can follow this YouTube link out there to see what the disease course of hepatitis C is like. So the main recommendation for screening is just looking for the antibody. The antibody tells you, have you been exposed to hepatitis C, yes or no? If that antibody is negative or non-reactive, then there is no need to continue any type of workup. If that antibody is positive or reactive, all it tells you is that that individual has been exposed to hepatitis C. It doesn't tell you if they actually have the virus or not. So the confirmatory testing that has to happen is what's called hepatitis C RNA, is actually looking for the virus in the blood. So this is a blood test, usually done either through a doctor's office or a health department that has the ability to send this out and screen for that virus. If there is no detectable virus, that means the individual has been exposed to the virus but cleared it on their own. They do not have any active infection. If virus is detected within the body, that means they have chronic hepatitis C, and those individuals should be linked to a provider who knows the nuances of treating hepatitis C and can cure the hepatitis C. And that is the goal for people living with hepatitis C, is treatment cure. And treatment cure of hepatitis C is defined as no detectable virus 12 weeks after completing therapy. And therapy should be available and offered to everyone, regardless of insurance status, substance use. There may be special considerations for individuals with late-stage liver disease, but this is now a disease that can be universally treated and cured and reduce the number of new infections and transmissions. There are numerous medications available for patients. These are the most common that are used in the U.S. A lot of the times it is a treatment course of daily therapy once a day for 8 weeks or for 12 weeks, depending on the type of hepatitis C virus. And as long as the patient can complete that through the course of therapy, there is approximately a 90 to 95% chance that they will be cured of hepatitis C. Again, another pictorial of what this generally looks like. The arbitrary number of virus at baseline that somebody may have in their system. They initiate therapy. Usually within several weeks, that virus is, within days to weeks, that virus is no longer detectable in the blood. Then after 8 to 12 weeks, at the end of treatment, that virus is still undetectable. And then a cure would be defined as 12 weeks after therapy has ended, there is no detectable virus. Again, patients may get reinfected with hepatitis C, but generally they will not relapse. Patients who have no detectable virus will stay cured, and that is the definition of treatment. So to bring everything back together, understanding the nuances and differences between hepatitis A, B, and C, and understanding that there is different epidemiology, different rates of transmission, and the screening for them is also different. You should be able to describe some of the hepatitis C care cascade, understanding how to engage patients in different aspects of that care cascade to get them treated and cured. There should also be some links either through health departments or through medical providers to get patients into care, understanding some of the medications and how the medications can lead to positive outcomes and cures. And lastly, risk reductions in resources for patients, looking to reduce the likelihood of contracting hepatitis B and C, looking at vaccines for hepatitis A and B, as well as other harm reduction strategies.